that is appropriate throughout any sort of healthcare setting. The word value medicine means doing the right thing for the right reasons at the right time for optimal patient care and safety. And that's what we'll be talking about tonight. The program this evening, if I can get my slides to advance here. Gosh, hang on a second. No, I lost that just a second. Bear with me a second, folks, here. That's what you get for talking too much.
And Dr. Moore, I'm happy to advance them for you if it doesn't
Well,
work.
Yeah, for some reason, there it goes. Okay, I think I got it, Mary. The program this evening provides 1 hour Category 1 physician AMA CME and 1 hour of Virginia Nurses Association CE credit for the program. Sovah Health is accredited through the Southern States Collaborative, a component of Medical Society of Virginia. Our nursing accreditation is through the Virginia Nurses Association. The program was developed to promote 2 desirable physician attributes, that of providing patient-centered care and always employing evidence-based medicine. Dr. Powell, our speaker, and Dr. Gunn, our moderator, myself, and members of the Sovah Health CME Committee have no commercial relationships to disclose to you this evening. And similarly, there is no commercial support for this program. The program is supported by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. This fund, established by Dr. Ralph Landis upon his retirement from the Southside Urology Danville Urologic Clinic, was an endowment that has allowed us to provide support for speaker honorariums and their travel when they're coming to Danville to teach. And we're very grateful for that support. This evening, you will receive for email a program evaluation. We ask you to take a few minutes to complete that evaluation and return it to us by email. On that evaluation, you'll see several questions. I think number 4 is the one that asks, what changes would you be making in your practice based on what you learned this evening? That's a very important question for us as far as the way we structure and evaluate programs. It is meant for everyone, not just the physicians on the calls. So take a few minutes and answer each question. In addition, the evaluation form will ask you to re-enter your name and your email address. Please give us your full name, not a nickname or short name, in as much as the name you put on that eval form is what will be on your CME certificate. I need to remind you also that we now offer a QR code that links to the eval form that'll appear in the chat box towards the end of the program. You can access the eval form through that, and if so, the email won't be coming to you. Sovah Health medical residents, and I know there's a lot on the call, you do not have to track your CME certificates. We notify your coordinators, Darrell Johnson and Ms. Galvez, of your participation, and they will keep up with that for you. For nurses, nurse practitioners on the call this evening, you must complete an eval form in order that your CE credit can be provided to you. Each time when I do a program or we do a program, I like to always take a moment and thank Mary Kent, our CME coordinator, and Van Holt, who is the nurse educator director for our market, for their help in developing these programs. They truly do all the, if you will, heavy lifting and the many documents, and I'm very grateful for their help. We encourage questions. I know Dr. Powell will be encouraging those from you. We hope you will speak up and ask questions or provide comments. If you do so, we ask that after you ask your question or make your comment, you mute your phone to listen to the response so we don't get feedback. On the other hand, if you have more than one question or comment, you are more than welcome, and we very much encourage you to do that. Let me just very briefly highlight a couple of upcoming programs through the remainder of this academic year. That's through June. Next month, as you may know, is a National Stroke Awareness Month and National High Blood Pressure Control Month. And to that end, we have two programs during the second half of May. On Thursday evening, May 22nd, Dr. Ryan, a Duke neurologist, will be reviewing the new American Heart Association updated guidelines on primary prevention of stroke. And then a week later, on Thursday evening, May 29th, Dr. Husseini, who is the director of the Duke Telestroke program, in which we participate as Sovah Health on both campuses, will be updating any changes and recommendations for acute stroke management, and also giving us a follow-up on the outcomes that have been realized through our working with the Telestroke program. It's been a remarkably successful effort, and it's always great to see how many folks' strokes have been either reversed usually and or really effectively managed to allow them to recuperate and actually get back to normal function. And then on June 5th, we'll have the last program for the academic year ending June 30th. And this will be a dementia review by Dr. Liu from, again, Duke University Neurology. Dr. Francis Walsh, who's a neurologist on our Martinsville campus, will be moderating that program. Dr. Liu will talk about diagnosing the various forms of dementia and the effective treatments that are currently available. Hope you'll be able to attend some of those programs. Well, this evening, we're very fortunate, and I'm delighted to have Dr. Sharanda Gunn-Nolan, our Chief Medical Officer for both of our campuses, to be on the call tonight. She's going to introduce Dr. Pawa and moderate the program this evening. So, Dr. Gunn-Nolan, thank you so much. It's all yours. And Dr. Pawa, you can bring your slides up, and that should all measure well. Thanks so much.
Perfect. Thank you. Thank you, everyone, for joining. I get the honor of introducing Dr. Pawa, who's a graduate from the University of Alabama for his undergraduate and graduate studies. He completed his medical residency at the University of Indiana and is dually board certified in internal medicine and pediatrics. His passion for education and research ultimately led him to his current role, serving at the Johns Hopkins Hospital School of Medicine as an associate professor of medicine and pediatrics. More specifically, these educational leadership roles include Director of Topics in Interdisciplinary Medicine, High Value Healthcare, Director of the Internal Medicine Sub-Internship Rotation at the Johns Hopkins Hospital School of Medicine, and Associate Director of the Core Clerkship in Pediatrics. He is nationally known for his work in high-value care, both in education and quality improvement. For his educational work, he has not only published several papers, but received many awards, including the Berkheimer Faculty Education Scholar Grant, the CDIM Early Career Medical Student Educator Award, CDIM Lewis N. Pangaro Educational Program Development Award, the HVPAA Educational Excellence Award, and the JHU Alumni Association Excellence in Teaching. I did get the opportunity to review this information prior to this evening's call, and I do look forward to this lecture. I want to thank everyone for joining. This was developed initially to be hospitalist specific, but there's certainly information here for all of us to learn from and not just specific to that subset of providers. As Dr. Moore mentioned, I will continue to monitor the chat during the lecture. If you have a question, please feel free to type that in that chat box or raise your hand. Please then place yourself back on mute so that we can hear the answer. At the end of the lecture, there is time reserved for Q&A, and Dr. Pawa, the floor is yours.
Thank you both so much for such a wonderful introduction. I'm going to go ahead and say that I cannot see anybody right now because I got my slides up. So please stop me if you want to ask any questions. As you can see, as my heart, I'm an educator, and I know that lecture is not the best way to learn. And so I want to make sure this is as interactive and useful for you guys as possible. Okay. So please, stop whenever you want me to and let us know. So I'm going to spend a little bit today talking about hospitalists and value-based care. As mentioned, I'm a hospitalist, both in medicine and pediatrics, and I got interested in this work actually when I started at Hopkins in 2010. I noticed that I felt that our inpatients were getting more stuff than they needed while they were hospitalized. So I have no disclosures, as mentioned, except that I think all of us, even as much as we try, we still practice some low value care. whether that be intentionally or unintentionally. And then I just want to make note, because I think this becomes a big thing in value-based medicine. I'm going to give many examples of really stopping certain practices, but I think we also have to remember value can actually be improved with increasing certain practices. I think a lot of the work that we've done, obviously, because patients are hospitalized, and that's an expensive part of their whole healthcare system, that not doing things during the hospitalization does save some money, but realizing that doing things for them sometimes can improve the value of their care during the hospitalization and during ambulatory care as well. These are my objectives, to be able to describe methods for implementing value-based care and give examples of value-based initiatives utilizing elimination and internal variation. And I also want to speak that I'm going to be talking a lot about the value-based initiatives we've done here at Hopkins. I'm not saying these are the only way to do this, and I'm not saying these are the only things to tackle. This has just been my experience with what I've been able to do here and improve the value of care for our patients here at Hopkins Hospital. So I think the big thing here is, what is value? And I think there are many definitions of it, many equations. I like to start with something simple. And this is actually available on a healthcare website, so is applicable to healthcare. But it's a very simple equation. Value equals quality over cost. I'm just going to stop there for a minute and let people kind of unmute and say, what are some things that can increase the quality and decrease the cost? Because those would be the things that would help with value. And let's talk specifically about hospitalized patients. You can also type in the chat if you're not in a comfortable place to talk as well.
And I'm watching that chat box,
Okay.
Dr. Paula.
I'm taking my requisite sip. As you're told as an educator, sip some water while you're waiting for someone to answer.
Got to communicate with the patients.
That's for quality.
Solid history and physical before you start ordering all sorts of tests.
Yeah, yeah. Anything else?
Patient education was mentioned.
Okay. Definitely. Anything that can decrease costs. I think these are all increasing quality. Anything that can decrease costs in hospital-based medicine. And as you're thinking of that,
Providing
I think-
access to meds that are normally expensive.
oh yeah, definitely. Because those may prevent hospitalizations, prevent ED visits, which are very expensive for our patients in our healthcare system. Love it.
Yeah, I mentioned using GoodRx or coupons.
Okay, great. So I want to say out loud that this is a very simple equation. And quality, there are a lot of things in quality that can be measured, and there's some things that can't be measured. And there's some of the things you said right there, like, how do I measure if someone took a good H&P? How do I measure if someone communicated appropriately, right? And people may feel a different quality of care if they were spoken to differently, but there's really not a good way for me to measure that. But sometimes our outcomes can be the quality that we're looking for. And so I want you, as we're going through this presentation, think some of the outcomes as hospitalists that we're looking for some of our hospitalized patients. And then costs also too, like, what is the cost? Like, who is it to? The healthcare system, the patient, and what is the true cost? I think many people, if they've read for 10 seconds about the US healthcare system, it is not a very open thing. And so determining costs can be a hard thing. So overall, I just want to say that value in medicine is a hard thing. And we try our best to kind of improve that for our patients by both increasing the quality and decreasing the cost in a simplified manner.
We did get a few more to chime in,
Yeah,
Dr. Paula.
yeah. Yeah.
Unnecessary CT scans of everyone coming in the ER and
Yeah.
length of stay was mentioned.
Yeah. And sometimes, labs or some things can lead to downstream increase in length of stay. I know that's all happened to us. So it might be a lab that eventually keeps a person in for another 24 hours. And CT scans can lead us down a rabbit hole sometime. So I wanted to show you value in this space of hospital medicine, and specifically on hospitalist spending. So this was a journal article from 2017 in JAMA IM, and in it, they looked at the Part B spending. So for those of you not familiar with Medicare Part B, that's like where the physicians come from, not the Part A, like the hospital cost. And they looked at the Part B spending, adjusted for patients, and looked at two outcomes that are very important to hospitalists. What days and whether a patient got readmitted in 30 days. And they found that no matter where people were spending, there was no correlation. It's not as if the higher spending person was getting a better 30-day mortality rate or a readmission rate, and it wasn't as if the lower person was getting a better one or a worse one. So you can see here that physician spending has done little to affect two big outcomes that we have in hospitalist medicine. And it's very interesting to see this, a data set like this that really shows no correlation or causation. Now you say, well, why is this occurring? Why do we have data that show this? And a lot of it, I'll tell you, has to do with imprinting. And I want to start by talking about a survey out of University of Pennsylvania where they surveyed both general surgery residents and internal medicine residents. And they asked them, what is the frequency and factors contributing to perceived unnecessary inpatient lab ordering? And 96% of them said that they, or sorry, 96, which is about 83%, said they saw unnecessary labs. And they almost half of them saw it on a daily basis. And going back to the imprinting part, you can see here some of the things that they said were that it's a practice habit. Lack of cost of transparency of labs, even though cost transparency of labs has not been that helpful and has had mixed data. Concern that the attending, I know that the residents here are concerned that the attending will ask for data and you won't have it. And then just the lack of role modeling of cost-conscious care. So there's this imprinting going on when we were residents that kind of shapes how we are after that. And if you look at some of the articles that came out shortly after this, because there's a lot of articles, or not just, but around this time, there are a lot of articles looking at, well, how do people spend once they leave training? So you do a residency program, and how well does that imprint you when you, or how much does that imprint you once you walk out of residency? Because you can just say, oh, well, I did all this in residency and it didn't really affect how I did once I left residency. And so what Dr. Chen did in this article here was to look at hospital referral regions. So if you're not familiar with the Dartmouth Atlas, I would encourage you to. It's something that Atul Gawande pointed out many years ago when there were two different areas in Texas that were spending differently, but they were having the same outcomes, and they were literally hundreds of miles away from each other. They weren't that far. So definitely look at where you guys are in the hospital referral regions. But what they do is they look at these regions that are kind of surrounded by these hospitals and say, like, okay, most of the patients in that area are probably going to use the healthcare parts in that region. And this is all Medicare data, since it's one of the largest insurance companies in the United States. And what they did here was they split people into low, average, and high as far as spending in those hospital referral regions. And you can see here, this data marks along really well with kind of it costs about $10,000 per person to Medicare expenditures per year. But what I want to draw your attention to is what happens if you train in the high region and you go and you stay in a high region, is that you end up spending more than your counterparts significantly. And even if you were in a low spending region and you went to a high spending region, while it wasn't significant, you still started increasing more. So there is some element to both imprinting with training in a certain region, and there's also some element of where you go after that to follow some of the trends. So this was to show that definitely there is some correlation with where you train and where you end up spending. And they looked at, these were PCP expenditures. So this was internists, geriatricians, and I believe pediatricians were included in this as well. I'm sorry, not pediatricians, just internists and geriatricians, because this is Medicare data. Well, I told you all about the healthcare system, and you're like, so what? The healthcare system is spending a lot of money. They're making a lot of money. Who cares? You know, but what about the patient sitting right in front of me? And the one thing when I first started talking about this is I couldn't really talk about, well, what are the ramifications for a patient? And then I read this article, and I think this came out in the New York Times or something, but it referenced the article I have there in the bottom right-hand corner and how a hospital visit can really hit someone's paycheck. And I was fascinated by this article because you can see here that prior to hospitalization, someone who's making about $45,000 has a significant decrease of about $10,000 after one hospitalization. And for those of you thinking like, well, you know, that's not a lot of money to begin with, that's about the average of what an American makes. And it really blew my mind that a hospitalization has all these downstream effects after, you know, on someone's paycheck. And a lot of it may be due to the fact that there's, as you can see here in the corner, out-of-pocket medical spending goes up. And I can just think of a big example right now where I recently took care of a patient who had a new onset heart failure. And of course, he's going to go on all sorts of the medicines and to prevent his hospitalization, but those medicines are going to cost him money. And many people think, well, this may just be people who are uninsured or having issues, or public insurance. But if you look up here in the top left-hand corner, it affects both uninsured and those with employer coverage just as much. So hospital admissions can really affect someone's life afterward. And it really gave me pause every time I discharge somebody now. And then the other thing that wasn't really that big before was downstream costs. Like, well, yeah, I ordered this test, but I really don't know what's going to happen after it, right? And so Dr. Ganguli out of Harvard did a lot of these studies. I know a lot of them are outpatient, and I apologize if they're outpatient, but I think they give us, again, some pause to think like it's not just one test. And in this particular article here, she looked at cascades of care after imaging for low back pain that may have been being valued by the healthcare effectiveness data and information set, which is HEDIS, if any of you guys have run into that as a quality measure. And what they found was that if you had X-ray imaging versus MRI imaging as your index, your cost went up either $100 or $500, depending on whether you had a high deductible health plan, or even 50 versus 200 for normal plans. And again, this is all the costs that come after that index imaging. And so people can say, well, $100 is not a lot, or $200 not, but can be for people on fixed income. So it goes to show you that it's not just one test, and we should really think about, for our patients, what does that test mean for them after it's over, if we don't think it's necessary. So this leads me, and I think Dr. Moore said this very well, what is the definition of high value care? And I think there's several that float out there. I know the ACP has one, and then there's some other institutions that have, or organizations that have one, but I really like the Institute of Medicine, and it's the best care for the patient with an optimal result for the circumstances delivered at the right price. So a test may be right for a patient, but just maybe not right at the time that they're seeing you in the hospital, or they're seeing you in clinic or in ED. It may be better at a different time. So I'm not saying that you don't ever order the test, but you may have to think, what does that patient need when they're sitting there right in front of me? I'm going to shift a little bit now that I've brought some background to this, to what methods of improving value have we done here at Hopkins Health System. We've worked in really 3 different buckets. And the 3 different buckets are pricing, standardization, and utilization management. I'm not fortunate enough to work in the C-suite, so I don't get to do a lot of the pricing stuff where it's negotiation. And I don't run our pathology lab where we've done a lot of internal sourcing. So I can't really speak to that, but that is a way to cut down on the cost aspect of the value equation, because of course you're not putting out that money to be able to pay for those things. I'm going to spend a fair amount of time on standardization, so that's through elimination and substitution. And I do have a couple of things on internal variation and benchmarks. So first, elimination. Some of you may remember, and then some of you have never probably ever heard of a CKMB, but I just wanted to bring up a test that I think to show you that there are some unnecessary tests that we used to order that we don't need to anymore. And I remember clearly as a resident, I would order this and a troponin. But some folks and of course, this is before the high sensitivity troponins. So please don't put that in here at all. But some folks over at Bayview Medical Center, over one of our Hopkins entities, performed a multimodal intervention to decrease CKMB in the evaluation of acute coronary syndrome. They just read guidelines that explain that troponin should be ordered in ACS. They removed CKMB and troponin from several order sets and had troponin only available in the acute coronary syndrome order sets. And then it would have a pop-up discouraging CKMB ordering. And this was prior to our unification of EMR. They Bayview used Meditech at the time that they were doing this. And I'm not going to belabor this because I think people don't really use CKMBs anymore, but these are great run charts to kind of show you pre-intervention versus post-intervention. And you can see here, right, CKMB, while it was decreasing, you can before the intervention, post-intervention, I mean, it's almost non-existent. So they did a great job of getting rid of an unnecessary test that wasn't helpful in acute coronary syndrome, and they increased the number of guideline concordant cardiac biomonitor ordering as well. So this was kind of the first forays that the Hopkins Health System had into high-value care. Now I'm going to shift a little bit to acid suppression therapy, and I put different ones on here to show that I wasn't like supporting one over the other. So please don't see this as any way of me supporting any type of PPI. In fact, after this is over, you probably don't think anyone should get a PPI. But I think a lot of us know that PPIs are great medicines for certain people, but oftentimes, and I didn't put a background here, I apologize. Oftentimes, they're used extended beyond their initial use or indication. And oftentimes in hospitalizations, we don't really change people's medicines because of our fear of causing problems afterwards and that discontinuity that we have with the patient that a primary care provider may not have, or that primary care provider may have. So at Hopkins Hospital, where I'm clinically working, at Hopkins Bayview, which I mentioned earlier, for 2 months, we partnered with pharmacists to assess patients for de-escalation of their acid suppression therapy. So that meant that they could either come off their PPI, decrease the amount of PPI that they were on, so go from BID to once a day, or alternatively go to an H2 blocker. And then they assess continuation rates in the 1-year period prior to the intervention and 1-year period after. This is an example of what note. So at this time we were in Epic. This is an example of a note that the pharmacist would leave for the clinician to see so that they knew that they could discontinue the therapy. So as far as the results, they found that 50% of patients had an inappropriate indication. So just as I mentioned before, that people were probably continuing on the therapy much longer than they needed. They had a recommendation of 60% actually stop their current therapy and 40% taper. About 80% of the recommendations are implemented, so a lot. Pharmacy time was about 5 to 40 minutes. I forgot what the median time was, but it wasn't very long. So the pharmacists didn't spend a long time on this. And they found that there was a 3% decrease in those that were discharged on a PPI. And this extended beyond the initial education phase, which was only for a couple of months. So I found it very interesting that education, which normally doesn't have a lasting effect, did for at least a year after we had done this. And it was at 2 hospitals as well. I didn't put a picture of C. diff because I know this is dinner time. I didn't want to disturb anybody. But this was another problem in our system, at least, where people probably did not understand the testing. And that, when I first started as a resident and a student, we had to send 3 samples for culture. And then the PCR came out. Well, the benefits of the PCR was it was much faster, and we were getting probably people ruled out for C. diff pretty quickly. But the also problem with it is that it creates a lot of false positives. And so people may be positive for the PCR, but not necessarily may be infected. And that causes a lot of problems with the Maryland health systems because we actually get dinged for everybody that is positive for C. diff during the hospitalization. It's called an MHAC, or a Maryland Healthcare Associated Condition. And these are things that kind of exist all over the United States. We just call them MHACs. So apologies for using that term, but that's what we use in Maryland. So a bunch of our ID physicians came and they said, you know what, we need to get rid of inappropriate C. diff testing. And What they did was they started this interrupted BPA, or OPA as it's called now. And what they had the system do was look to see if the patient had at least 3 unformed stools in the last 24 hours. If they did not receive a laxative in the last 2 days, and based on the positivity results. If all those were not met, then they got this BPA. At this point, about 15% of the people stopped it. They didn't proceed with the order. Those who did then got this, where they said, you really shouldn't be ordering this test. And this was the hard stop part. They had to read this little thing, these 1-minute guides here that kind of said that, why we wouldn't order C. diff in every patient with diarrhea, and that we should really be thinking about it. And that if you really wanted this test, you had to call this number. About 60% stopped at that point. So this is, if you guys know the new term of sludge, making things really harder for people to do. This was a huge thing and stopped a lot of the C. diff orders. There's, of course, if you had 60 plus 15, you realize there's still 25% that called that number and still had their testing done. But what I wanted to show was we did it at 3 different of our hospitals. One was Johns Hopkins. One was Howard County, which is located actually close to where I live, in one of the suburbs. And the other one is Suburban Hospital, which is located close to DC, in Montgomery County. And what you see here is, again, run charts. The one on the top is number of C. diff orders. This line is when we got the OPA starting, and you can see there was about a 10% reduction at every hospital. But what they also had to look at was, did we make sure that we didn't miss anybody with C. diff? And that's what the bottom line is. The bottom line shows you that, no, the number of positive C. diffs did not change over time. So we really eliminated the people that did need to get it, probably saved them a test, probably saved them a false positive in case, and just one less charge on their bill that they probably didn't need. I think the biggest thing that I've been trying to do, and I think a lot of us as hospitalists are really championing, is reducing repeat labs. And we've gone through a couple of different ways of doing this. This way was of a targeted reduction with an informative BPA in hospitalized patients. So we met with respective groups with each one of these labs. So, for example, lipase was with the GI, hemoglobin A1C was the endo, lipids were with cardiology. And we asked them, if a patient was hospitalized and they had these tests, what is too early to get that test? And they gave us these dates here, our time frames. And we said, okay, we're going to institute an informative BPA that if, for example, and I'll show you, the first one we did was hemoglobin A1C. If a hemoglobin A1C is ordered on one of our patients while they're hospitalized, not outpatient, and they had a result in our system less than 3 months ago, they'll fire this informative BPA. So a patient has a hemoglobin A1C, and even if it's in progress, although if it's been more than a few days, they should have a result. But if it's been resulted in progress in the last 90 days, it would pop this up and say, you don't need this anymore. Now, of course, it was a soft stop. They could go through and they could click that clinically indicated and move through this whole BPA. But it was our thought that our EMR is so muddled and very hard to get some of the data that sometimes clinicians are not ordering because they think it's necessary. They just don't have the latest result and would actually stop. What we found was, amazingly, for hemoglobin A1C, that was the case. So I know this is and this is a faux pas of any lecturers to say this is a busy slide, but what I want you to see here is that blue is the number of times this fired. Yellow is the number of times someone accepted it and said, you know what, I'm not going to do this. And orange is the times people proceeded. So you can see maybe 70, 80% of the time people said, okay, you know what? There was one 90 days ago. I really didn't need it, and I just couldn't find it, probably. And I'm just going to show you a few different ones in the system here that we did as well that had variant results. So hemoglobin A1C was actually a big success. ESR was decent. So here again, it was probably about 25% accepted and about 75% still proceeded. This was a 7-day, I think, would pop up. TSH was huge. We actually got, pretty decent numbers with that one, although still about half proceeded with it. Iron TABC was pretty fair. Oh, sorry, this was, I am so sorry, was supposed to be hepatitis C antibody. Hepatitis C antibody was pretty fair. You can see here that even though it fired a fair amount of times, a lot of people still proceeded with it. And I'll skip that slide because that was a copy of the other one. What I really want to show you guys, and I realize this I don't have this year's fiscal data yet, but it's pretty similar to this one in the few months that I have, is that this provided real cost savings for our health system. And the numbers you see here are the true cost to the health system. There's not the charge that goes to the patient. There's not the charge that we put up on our charge master. This is the true cost of at least the reagents and the machine time for each one. So about $20-some thousand a month in just lab cost alone have been saved by doing this. So I'm going to take a minute to now shift towards internal variation. And this was one of my favorite projects to do because I got to see different cycles of it. And it was nice because I mentored different residents during each time, and they got to do different parts of it. Specifically, on telemetry. So when we first started with telemetry, we were in the Sunrise system, and when I first started at Hawkins, you walked around, literally everybody was on telemetry, and there was no way to get people off. When it was ordered, it was a very easy order to go through. And what we said was, well, let's put some restraints on the order a little bit and see what happens. So the first thing we did was when we were in Sunrise is we just put this little message that said, you know what, there's some indications you probably don't need telemetry for. Really think about if you want to proceed. And it didn't stop the person. It just kind of was like a quick informational message there. We were actually restricted, I think, to like 250 characters or something. So we got really creative with these in Sunrise. And this is just the order set. Specifically, what I want to pull your attention to is that this was what we called our nurse protocol. Very similar to what they did out at in Delaware, Christian Healthcare. I was trying to remember the name of the place. We had piloted on one of our floors, and it was a success on that floor. So then we moved it to all of our internal medicine floors. And this was the first part of it where you had to order it. And then, amazingly enough, this was the first time we were putting indications in. So prior to me even doing this, we never put in indications for telemetry. It was just ordered. And based on whatever the clinician picked, it would alert the nurse to review the telemetry at that period. So 24 hours, 48 hours, whatever it may be. And the nurse, let me see, but yeah, the nurse would actually message the on-call physician, a clinician, and say, you know what, there were no events over telemetry. It's been 24 hours. They were on it for, for chest pain syndrome, let's say, for example. Is it okay to stop it? And most of the time, the resident or the clinician would say, sure. And it worked out really well. I think all university, at least the residents, loved it because they were, they were getting help and trying to get rid of people off telemetry, so they loved it. Unfortunately, in 2016, or fortunately, whatever you want to say, we moved to Epic, and Epic said you cannot do a nurse discontinuation protocol, at least the one we bought. So we had to do it on the physician side. And so we kind of adapted it just so that the physician, the order was the same, it just looked different because it was Epic. But instead of the nurse getting the indication that, or the notification that it was time to review it, the physician did. And it looked just like this from about 2016 to 2019. And it was pretty plain. And what we found was that really, I'll go over this in a minute, but, there wasn't much to do with this. Like, either you could, you have to go to a separate screen to discontinue it. And that will discontinue telemetry down there is just a promise. Doesn't necessarily mean they actually did it. So this was probably not the greatest BPA we have in the world, but let me show you some results from it. So, oh, someone's going to say something? No. Okay, so we looked at mean telemetry hours per month, and if you can see prior to the green line, we were running at about, and I want you guys, if you can try to remember these numbers, because I got a few run charts here. We're going about 80 to 85 hours per patient per month. Or sorry, per patient per day. Or sorry, per patient, I apologize. And then we dropped to about 70, which was significant when I showed you that first nurse discontinuation. And then we went back up to around low 80s, which was still a little bit less than prior to no protocols, but was kind of disconcerting that our physicians worse, or clinicians worse at this than nurses. And they said, well, why don't you go back and look at how many orders are put in? And this is actually where I found the best data, was that the telemetry orders per admission per month went down hugely when clinicians were both had to put it in and being notified that the time on it was up. So this is a huge win for us, that we were able to get this down, because I would just tell you, I've been at Hopkins, but prior to this was started. And when I walked around in 2016, 2017, there were less people on telemetry. So that's why I was surprised that people have been on longer. And our conclusion was that probably people who needed to be on it stayed on it, and probably the low risk people came off of it pretty quickly, or were never ever put on it, which was kind of cool. And we really hit this as a big win. The problem with it, though, that I didn't mention earlier, was that it was ignored a lot, the BPA, when it popped up. And a lot of it had to do with the fact that you could not manage the orders from there. And so you would have to go to another place to do the orders. So after 2019, we created this one based on what they were doing at UCSF. And I think some of the New York hospitals are doing this similar system too as well, and published in JHM. But we made it in a way that now the clinician can discontinue it from the actual BPA. So you can see here, the clinician got this pop up after 24 hours. And they found that, here it just showed why it was on for 24 hours. And here they can say, I want to discontinue it. I can address it in an hour, I continue telemetry. And then the other thing that we did too was, because this was firing at all random times, because if it was set to fire at 24 hours, it would fire from 24 hours when the order was put in. So if an order was put in at 11 p.m., it would fire 24 hours the next day, which a resident during that time may not know why the patient was on telemetry. So we restricted it to only 8 to 6, so that the primary person that was taking care of the patient was there and would probably understand why they needed to take it off. And you see here, and I said, remember the number 80, because we were even able to go down more, from about 75 down to around 60 hours at the start of that new intervention where we had that new BPA. And this is the old one where you couldn't discontinue, and this is the new one where you could discontinue from the BPA. And this is these hospitals here are, again, our JHH and JHBMC, Bayview. And the reason those are combined together is because they're considered our academic medical centers. That's where our residency programs are based out of. And then Howard County, as I mentioned before, which is one of our community centers, had decided to do this as well. They actually had nothing before, and then they put in the BPA, and you can see here they had a pretty significant decrease from about 70 down to like 45 hours, and they were super happy. And both of these were maintained pretty well after. And another thing that if you don't really realize in here, because it's been such a long time, this is also during COVID too. So we went back and looked to make sure there wasn't like a crazy uptick during COVID that may not have explained some of these data, and there wasn't really a big one. The other thing that we looked at too was were the number of BPAs being used appropriately and not being ignored, because if someone's getting an interruptive alert, we want to make sure that it's not for just interruptive alert's sake. And honestly, this was the disappointing part of it. We didn't really get a big change. We actually got a change on the upside that more people were getting more BPAs. So it didn't really decrease the amount of BPAs. It kind of increased them just slightly up. But what we did end up seeing was that people were more likely to interact with the BPA more, and there was more of an increase in intent to discontinue telemetry when the BPA was made in a way that they could discontinue it from there, and they could, it was only firing from 8 to 6. So the other aspect of daily labs that we did, and this is where the firms will come in, Dr. Moore, a little bit, is how do we get people just to reduce daily labs overall, not just the ones that are, that time period we talked about, like the 7 days, 3 months for some of those labs, but like the daily labs that we're getting our patients, is there a way we can reduce the frequency that we're getting on them? So what we did was we did these audit and feedback methods with our house staff. And the fortunate thing, as Dr. Moore, if some of you were on, was mentioning, so, and I forget when it was, but when Dr. McCusick was chair, he created the firm system here. And so the way the firm system works is that when a resident enters into residency here, they're assigned to one firm, much like they are in Harry Potter. So if you read Harry Potter, it's the same thing, it's 4 houses. And they do all of their general medicine time on that firm. So for example, if they were Barker firm or Thayer firm, they would only do their general medicine time on Barker or Thayer. They would not cross over. Now, of course, the interns had other rotations, and some special rotations that they did with crossover with other firms. But for the most part, their general medicine was on those, and they did anywhere from 6 to 8 months a year, depending on the academic year, and if they were categorical medicine versus some of the combined residents like myself. So what we did was we used academic year 2017 as a control, and we looked at like what were the orders and blood draws per patient day from the first half to the second. Then in 2018, we created this weekly email with a dashboard. I'll show you a picture in a minute. And we gave it to 2 of the firms, and we saw what the blood draws per patient per day were in orders. And then we took it away from them and gave it to another 2 firms. And again, the reason we were able to do that was because they spend all their general medicine time on that. And they would only get this when they were on general medicine. They would not get it if they were doing a different type of rotation during the time, like ambulatory or a subspecialty. And then in academic year 2019, we tried a different type of audit and feedback method where we basically met with this house staff every month during their monthly house staff meeting, and we gave them their firm level data. So we said firm 1, had this many orders per patient per day or blood draws, and then we rewarded the team with the best order rate and stick rate. And then, again, we looked at the first half of the academic year and the second half of the academic year. You guys can kind of guess what's going to happen. Oh, I forgot to tell you, here's a picture of the dashboard. Pretty benign. We call it OSER care because we wanted to have some remnants of OSER and kind of how he really talked about clinical medicine and being with the patient at the bedside. And you can see here that the resident would get like how many orders per patient per day they were doing, how many sticks or blood draws they were doing, and what the average was. And if it was green like this, it means they were below the average. If it was red, they were above the average. And then they could kind of see down here too, what are the different labs that they are doing that are either more than their colleagues or less than their colleagues. And the blue was them. I'm sorry, yeah, blue was them and orange was their colleagues, average. And then you could also see how many patients you're seeing too, so that you would know that, I'm seeing a lot more patients or I'm seeing less patients, just to show the volumes of patients they're seeing. So it was a really nice thing. They went straight to their email every week through the system. So what I want to highlight here is, and this is specifically orders per patient per day, that overall, if you look at all the academic years together, I'll just point that out, that it significantly went up. So from the first half to the second half of the year, which we didn't expect because we thought the interns would be more experienced, it actually went up. But if you look at the time we did the audit and feedback with the weekly emails, the early intervention people did the same, they went up, but the people who got it in the second 6 months of intern year actually didn't change. And in fact, may have went a little down. And so we hypothesized that possibly we bucked the trend that has been occurring every academic year before that and even after that, orders per patient per day going up. We didn't see anything similar in sticks per day or lab draws per day. But again, you can see here that, again, the first half to second half, they kind of stayed pretty low in that intervention, the late intervention people. Oh, and I forgot to mention that an order was a composite order. So if they ordered a CMP, that was considered one, not 9 different orders. And a blood draw was considered anytime a phlebotomist had to actually put a needle in a patient. We were able to record that in Epic. The only time that it got double counted was a blood culture because that had to be stuck at 2 different places. And we excluded anybody with a central line because everyone was getting their lab from a central line. So we really tried to clean up the data so that it was purely people getting stuck and only serum labs, not a urine analysis or urine culture or sputum culture, anything that didn't require a venipuncture to get. And then, I just wanted to say that we also looked at a balancing measure on this because we were trying to see if by decreasing the labs, were we increasing inappropriate things by ICU transfers or coach RRTs. And we didn't have any changes in those between any of those academic years or academic breaks that we had, no matter what the residents were getting. So I think it was all something we knew anyway, that lab draws and lab orders really don't affect patient mortality or patient transfers. And I forgot to mention that back in the telemetry one, not in every study, but at least the first one, we looked at the number of codes and RRTs during each period and made sure that there wasn't an increase in the number of codes or RRTs when we decreased the amount of telemetry. So I wanted to, I talked for a lot and I'm sorry, I apologize. Think what value-based initiative you like to start based on kind of all things that you have. We're kind of, if you're near someone, you can pair with them and share, but I think we're all on teams, so it's kind of hard. So you can unmute and share or share in the chat. And, I'll kind of pause there for a minute to listen to what people say.
Yeah, Dr. Paula, we do have a comment from Sally Ann McIntosh. She said, "Good evening, everyone. Excellent presentation, Dr. Paula. As a career-long hospitalist, I felt compelled to pursue some incidental findings on imaging primarily in the first 5 years of practice. This is not cost-effective by most measures. How do you address incidental findings like a thyroid nodule, pancreatic cyst, or renal lesion, especially when concerned that the patient has no established outpatient care, no payer source, and will be lost to follow-up?"
Yeah, that's a tough one. I just ran across that because there was a gentleman that got hospitalized and in between him being at Hopkins, like he was here like in 2014 or something, and just again now in 2025. In between that, he went to the VA. So I had no records of what happened to him, but we did clearly show that there was a thyroid nodule that was bigger, or a thyroid nodule or mass that was bigger then than there was now. And I really pushed on that one to get it because I didn't know what his outpatient follow-up was. And interestingly enough, the hospitalist told me I couldn't do it because he was an inpatient and they only do it as an outpatient. But some of those other things, the way the Maryland system is, I end up doing it. And when I say what the Maryland system is that we're not, we're an all-payer source. So a CT scan is not different if we do it inpatient versus outpatient. It's the same charge to the patient. And so I'll end up doing it. And sometimes I'll end up doing it for convenience sake too, that if it helps the patient not get it as an outpatient. But I also have to think that will will that test be okay now? Like, because patients are acutely sick. And will that test be something that we can interpret in the time? But I've done it. I think we all have. And I think a lot of us take care of patients that don't have good outpatient care, which we know outpatient care saves money too. That was the other thing that I would say too. Increasing outpatient care and PCPs would help save money too, which has been shown in the data. I hope that answers your question.
Yeah, I will say as CMO, these topics come up quite a bit for these incidental findings, and I think it does
Yeah.
become case by case. Virginia is not an all payer source, so we really have to be careful with what's inpatient and outpatient designated because it can create a hefty burden for a patient if we do them inpatient. But it does become a case by case.
Yeah, and I think where I was when I was in Indiana, it was the same thing, right? They really pushed to make sure some tests were not done as an inpatient. VA is specifically that way. They did not like any screening ultrasounds done when the patient was hospitalized. I have anyone else want to share? While you guys are thinking, oh, go ahead. Sorry.
Sorry, this is Amanda Green in Paris. I'm sorry I got on late. So you might have talked about transfusions, but that's something we're working on is why give 2 and 1 will do. So that's one of our initiatives. And then the other one is renal biopsies. We do a lot of renal biopsies in-house, and it costs so much to send off all of those markers when it's better to do it outpatient. So that's really hard for us, I think, in our facility to send somebody out and have them come back. Again, the convenience, will they come back? And it has implications for the dialysis.
Yeah, it's interesting you say the whole blood transfusion thing. That was a big thing by Steve Frank here. And I remember walking around seeing all those screens. So yeah. And then when I mentioned negotiation, I remember Steve negotiated for cheaper blood products too, because that's basically a check you write to the American Red Cross or whoever, because it's not something you may have blood in house for the most part. I didn't know that about renal biopsies. I don't really dictate those. I mean, I let renal say it, and I find half the time they don't want to do it because they're like, it's not going to change what we do. I think I just had, let's see, I just had one more slide that I'll put up here and while we're doing questions, but and I think Dr. Moore was involved in this too. But the High Value Practice Alliance, this is actually how I got connected with Dr. Moore. Pam Johnson or Dr. Johnson, who's over here at Hopkins, who's our vice president for care transformation, started this alliance a while back to kind of promote high value quality improvement and getting centers to actually present to each other and collaborate. I don't know what that QR code goes to. I bet it's dead because I bet this is an old presentation. This is an old slide. But do go to the website. I know it says hvpaa.org. That was because we were the academic alliance and we realized that we're not just academic hospitals, we're also academic and community. There is no national meeting. We're retooling it. So please keep an eye on the website for other things that are coming up. But there are tons of abstracts on there, tons of resources if you want to use for your high value kind of practice, and just lots of great stuff. Great resource for anything high value related.
We do have another comment from Ashley Navarro. She's a new grad nurse here on the medical surgical floor. Is there anything about central line usage and reduction of CLABSI that could be said from this standpoint? And Ashley, I will say absolutely, but Dr. Paula, the floor is yours.
Like how to get rid of it or?
Yeah, from a cost reduction, a correlation, central line usage and any reduction in CLABSI. And the first rule of thumb is don't place the central line.
Yeah. I mean, I think here, that's another MHAC too, right? Maryland Healthcare Associated Condition if they get a CLABSI. I'll be honest with you here, and I think you said you were a nurse. I think at least at our institution, the nurses are more vigilant about it because they carry this pride that floors can go like a year or 2 years without a CLABSI, and they celebrate it every year. So they do have that aspect of celebration when there's not a CLABSI. But I would say our nurses are really good at advocating if a patient needs a line or not. I think it's part of the reason is because they themselves realize that when a patient has it too long, bad things can happen. So I think many of our nurses are advocating for that. And I'll be honest with you, as a hospitalist, we have not placed central lines for the most part on patients, like on the general medicine floors. They may have come from the ICU, right? With it, or I know, for example, there was a person with dialysis, right? They might have a Shiley or something, but we really push to get those out quickly. I think that's the big thing. And I think the other thing they're doing here is chlorhexidine or it's some wipe that they make us order. I don't know if it's not chlorhexidine, it's something else that this is bundle that I have to order now. Again, that was nursing driven that they wanted that order set put in to decrease CLABSI rates.
So I will say, Ashley, here at Sovah, it is nurse driven as well, but this is the
Yeah.
reason why we try to minimize central lines, optimize midlines and things like that if access is an issue, so
Yeah.
that you can avoid the central line aspect altogether, and then remove that central line prior to transfer to the floor if possible, getting an alternate IV access.
Yeah. Oh, is there anything in the chat I missed? I think did you say them all, Dr. Gundolan?
Yep, we've got it
Oh.
all so far. Any other questions anybody has? This is good discussion.
Yeah, CHG wipes. That's it. I knew it was something. with a
Leave it to
C.
Sarah, our ICU director.
I'm sure what we're using at Hopkins is not something that's like magical. I'm sure it's something nationally driven. But I remember there was a big order set push to put CHG wipes on our central lines.
Any other questions?
Oh yeah, please do. As an educator, please do the evaluation. It's a way to show the people here if they're giving you the right content. They do look at it. I know I run CME courses all the time, and I look at it heavily when I'm thinking about the next thing that I'm doing. Oh, I was going to ask a question to Dr. Moore. What was that a picture of on the Duke? The Duke people that are coming to talk about hypertension. Was that it said something about hypertension, like something about saving lives or something, and the doctor was holding something. I didn't know what it was. He may be gone.
You mean on the upcoming programs?
Yeah, there was a picture in the top left-hand corner or top right-hand corner, and the doctor was giving something to the patient. I don't know what that was. It looked like cigarettes, but I didn't. I was trying to figure out what that was.
Let me go back and look. I'll have to look on my other computer here just a second.
That's okay. Sorry.
I think that was the National High Blood Pressure Education logo.
Okay.
Sorry, I'm struggling here.
No, take your time. I'm waiting for questions too. Although it is 8 o'clock, so I know people are probably like, I want to go home or I want to go to sleep.
Yeah, why don't you go ahead? I'll try to find that slide for you. We can talk about it a moment later. Thank you there.
I think we're all questioned out, Dr. Gundolan. All right.
It does
so
look
much.
that way. I will say while we wait for Dr. Moore, I can hear your frustration in trying to get other colleagues to join in on that process. How do you carry those conversations with physicians that are pretty stuck in their habits and ways? Is it persistence?
Oh, yeah. I was just actually thinking about this morning because I was dealing with something else which I was frustrated with because I'm passionate about value-based medicine and reducing costs, and I think that some of the methods I think you really have to be careful about the methods because you got to make it, going back to the whole sludge thing, right? You got to make it easy and not frustrating for people. And if you're going to frustrate people with something, it has to be for a pretty good reason. And, I didn't really mention, I guess I deleted one of the slides and I apologize, but the one thing that the telemetry thing taught me a lot about was that you can't just set something and forget it. We rested on our laurels of the fact that we had decreased in the number of orders, but eventually someone came to us and said, well, the BPA is annoying. I'm getting it at 10 o'clock at night, 9 o'clock at night. So I think always going back and making sure that for the user, it's the easiest thing for them to go through. This is the human factors engineering that we're as physicians and Epic is not good at, right? When you think of human factors engineering, people who do a good job at it, it's people who make like your iPhone and your MacBooks, right? They make it super easy to use. And I think that's where you have to go. I will always say people want to do the right thing. You just have to make it easy for them to do it, and not frustrate them is probably the end of it. But there are going to be people who I anger. I know. I do it also as an educator. I'm like, fill out your evaluations. And that was actually, Dr. Gondola, what I got frustrated about this morning was I couldn't fill out an evaluation on someone because my computer or the system software was messing up. And I got frustrated at the person that like runs that program. And I was like, I'm a medical educator and I'm getting frustrated. So how do you expect someone who's not a medical educator not to be frustrated by this?
Yeah. I feel like we had a very similar morning.
Oh, okay. So what
Is that it? Is that what you were looking for?
are they I don't understand what he's holding.
Sorry. See if
It
I can
looks-
make it bigger.
No, I looked at it. It looks like a pack of cigarettes. That's why
Oh, no, I found the slide. That's one of the promotional slides from the National High Blood Pressure Educational Program, circa around 1980. It's an NHLBI slide in which that was around Joint National Commission reports 2 or 3. And what the physician's holding is his blood pressure record card. So at that point, the whole point was know your blood pressure, which was later adopted by the National Cholesterol Program, Know Your Cholesterol. So the point was that when someone takes your blood pressure and they say it's okay, that's not appropriate. You should give them the numbers. It's the patient's blood pressure after all. So they should become aware of what the number is, and then of course be knowledgeable about whether they are at goal or not at goal. It's also an indirect way to hold the physician accountable. If they're not at goal, the patient actually knows that and can interpret his own or her own quality assessment of the care they're getting. So.
But we do have another comment from Sally Ann McIntosh. I found that translating the value-based testing and care into my board review preparation for recertification every 10 years helps quite a bit in answering questions correctly. Yes.
Yeah. I was just with a student and they were doing a midterm for their PEDS clerkship and they answered to consult somebody. And I said, that's always the wrong answer on a question because they want you to deal with it yourself before you go ahead and consult somebody. So you're correct in that. And I think for a while, I forget which exam it was, whether it was the in-training exam or was the actual initial certification exam. They had classified questions as like conservative measures or conservative, like it was a conservative answer and then appropriately like elevated answer. And that the people from, again, going back to that low training region, it was the same authors. They went back and looked at that and they found that the people in the low training regions were better at being appropriately conservative and appropriately aggressive at the right time. So another shout out to being in a place where you don't spend a lot of money is when you're supposed to escalate and when you're not. There was a lot of articles about that stuff in 2016, I feel like 2014, 2015, because that was like a big, like choosing wisely was coming out, right? And so people were like, it was a hot topic at the time.
The other dimension to that is when you ask for consultations, being the primary provider or the attending of the patient, it's really so important that you as the attending take that consultation as recommendations you don't just hand the care over necessarily.
Mhm.
Everything they ask, you really need to be an educated filter about how
Yeah.
that can you sort out your patient's problem or interpreting it for the patient. So many times you'll get a consult and they expect the consultant to take care of the patient. And it's really important as the primary attending that you get the recommendations and you decide and talk to your patient and decide which to use and how to go forth with that, you know.
Yeah.
It's easy to punt and not do that, but that's what we should be doing.
Yeah. Shared decision making. And then consultants here at Hopkins, I'm sure where you are too, it tends to be learners, right? So fellows talking to interns and so young clinicians talking to each other that may not know when to be appropriately conservative. I think, going back to again those studies, all that stuff about people being like high spending and low spending tends to fizzle out after about, I think, 15 years or something. And then everybody's the same. So it's that like post 10 years after residency where you're really different. And then 15, 20 years after, you're kind of everyone's just the same. They don't do anything.
Yeah, you relax a little bit.
Yeah, well, it's everything you've seen, right? You just
Yeah.
know like how this is going to play out, and you're just like, whatever.
Yep.
Well, it's developing a confidence that you know what you know and you don't know, hopefully.
Yeah.
Sometimes we never get to that point, some of us, so it's sometimes not that easy, but that's what translates into being what I will always call an RD, a real doc. Even though you're an MD or whatever, or you're an RD, so it's tough. So do we have any more questions, comments, or materials for anyone?
There's nothing else in the chat.
Dr. Paula, any final comments before we fold our 10 here?
No, I appreciate you all letting me talk to you this evening. I know it took time away from your family, and I appreciate you giving me your ear for this hour. And hopefully you learned something.
And Dr. Gunn, any final comments?
I just want to thank everybody that joined. I recognize Amanda Green is another CMO, and we have people from all across, not just our Sovah folks on this call. So I appreciate everyone that was able to join. I'm happy to see that this is a broadly accepted topic that we need to have more discussions about.
And I also know Dr. Paul will be happy to have any questions that people have as they go back to their daily work, and you can reach out to him. He's very responsive to questions and thoughts and advice that he can help you in your care of your patients. Dr. Paul, thank you so much. Also, Dr. Gunn Nolan. I'll remind you it'll be about 3 weeks now, May 22nd. We do hope you'll be back with us for the review of the updated primary prevention of stroke, which is something that all primary care providers need to be aware of as the guidelines have changed a little bit. But that being said, please, as I tell our residents when I gather with them, please be careful out there. And we hope that basically you'll have a good evening, and thanks for being with us. Take care and good night. Bye-bye.